Good afternoon, everybody. So, yes, I'm Inga Rosner. I'm from Walter Reed National Military Medical Center, Bethesda. I was at Walter Reed Army Medical Center, and then due to the base realignment and closure, Army and Navy have merged, and now we're one big institution across the street from Dr. Apollo at the NCI. So we're on Wisconsin Avenue. This afternoon, I'm going to be talking actually about the surgery to remove the bladder, called a radical cystectomy, and what that entails. Indications for cystectomy typically are invasive, muscle-invasive bladder cancer, or in certain situations, high-grade T1 disease and CIS. Certainly, in other operative procedures, we remove the bladder in GYN malignancies, and there are other indications to remove a bladder, but typically it is for invasive bladder cancer. The goal of the surgery is actually in men to remove the bladder, prostate, seminal vesicles, and lymph nodes. In women, it's to remove the bladder, uterus, fallopian tubes, ovaries, and part of the anterior part of the vagina and lymph nodes. And then the other major component of the surgery is then the reconstruction, because obviously your bladder acts as a storage device for your urine to then fill. It's a sphere. It fills with urine. There's a sensation to urinate, and you urinate. Obviously, when we remove the bladder, we have to then create a reconstruction to sort of make a new bladder, and that is done using different parts of the intestine. The risk of surgery, and really this is any surgery, and I tell this to all patients from minor procedures to a major surgery, including a radical cystectomy, which I think is one of the most complicated procedures we perform as a urologist, is bleeding, a risk of blood transfusion, infection or sepsis, which is infection within the bloodstream, injury to adjacent organs because your bladder is adjacent to your colon and rectum and intestines. Part of the lymph node dissection, you can have something called a lymphocele, which is a collection of lymph. Obviously, a deep vein thrombosis or pulmonary embolus, a heart attack, and prolonged hospitalization. So it is a very significant surgery. The steps of the surgery. And before I even sort of get into the steps, in the last sort of 5 years, I would say, for bladder surgery, most people are approaching a radical cystectomy, either one through an open procedure where we're actually making an incision in the abdominal wall, versus robotic-assisted or laparoscopic procedure, which is using smaller ports and blowing up the belly or insufflating the belly with gas to create a working space. So there's really sort of two different methods to remove the bladder. Here in this particular talk, I'm going to go over the open procedure. The steps of the surgery, again, is a midline incision, typically a little bit above your belly button, around the belly button, and down to your pubic bone. There, your bladder, at one point when you were in utero or in your mother's uterus, your urine or that urine would drain through the belly button. And so part of what we do is to grab the urachus, which is right up there by the belly button, and then go down and dissect the bladder out from there. When we're doing that, we're also, you can sort of see in this picture, this is sort of this midline incision. This is the urachus, and we dissect that out and then follow that down to the bladder. And then at that point, we identify the ureters. So the ureters are the tubes that drain your kidney down to your bladder, and we identify these. At this point, we will then send a frozen section of the ureter to make sure there's no tumor or anything involving your ureters. And we then ligate them, and eventually when we're doing the reconstruction, plug in those ureters into your new bladder or whatever we've created to drain your urine. After we've removed the bladder, we do a lymph node dissection. I have a picture of that coming up. The next part of the surgery is to then make a conduit or a reservoir to hold your urine, and that's mobilizing whatever intestinal segment we may use. The goal of this new device, or not device, but new storage collection is to store the urine. We want that urine to be stored in a very low pressure manner, because the pressure then, if it were a high pressure system, would then go up through the ureters and potentially affect your kidneys. And our goal is to maintain good kidney function. And continence, not to leak any urine from this new storage, and empty completely, and also maintain a quality of life. this is what the actual lymph node dissection will look like, and these are the vessels that bring blood down to your legs and then bring it back up to your heart, and we remove all the lymph nodes in this area. And the goal for that is proper staging and potentially a benefit if there's micrometastatic disease in those lymph nodes. The next part of the surgery also is then plus or minus a urethrectomy. Your bladder drains through your urethra. Your urethra in women is very short, in men it can be longer. And in certain indications, we do have to remove the urethra as well. And again, these are sort of modifications and techniques of the radical cystectomy over years. Prostate sparing, nerve sparing to preserve potency and erectile function in men. Gynecological sparing, maybe not taking ovaries, sparing the anterior vaginal wall, which can be important for intercourse after surgery, urethral sparing in men and women, and again, the robotic-assisted technique in laparoscopy. So in terms of types of diversions, there's really 3 types of diversions. And when I say diversion, that means sort of how are we going to store your urine within your body or outside your body. The first is a conduit, where we basically take an intestinal segment and then we bring that intestinal segment out to the skin, and you wear an appliance that will then collect the urine. And I actually brought some of these devices around if you want to pass them around to see. And there'll be subsequent pictures, but thanks, Grace. If you can pass these around, these are what the device is. The hole here is where the stoma would empty into the bag, and there's adhesives that then would help this stick to your skin, and the urine would drain and collect in here, and you would empty every couple hours this collection device. And there's several of these around. So that's called a conduit. The next type of diversion is a continent reservoir or a continent diversion, where again, we haven't created a new bladder to urinate through your urethra, but we create a reservoir that then you can has a very small stoma, and that you would then put in a catheter. And Grace, I have one more thing to show them. Where the patient would then place a catheter, very much like a catheter when patients are getting BCG or other things through the urethra. This catheter would be placed through a very small stoma that is at the skin level, and the patient would empty the reservoir within their body doing this. So it preserves the skin in the sense that there's no external appliance that a patient would have to use. And then an orthotopic diversion, or a neobladder, where we basically create a new bladder, and it's anatomically sitting in the location where your bladder is sitting now, and you would urinate out of your urethra. So there will be no external appliances or devices that would need to be used to empty the bladder. And this is just sort of a schematic of how these diversions look. This is the continent diversion, so the kidneys are draining the ureters. We've created this sphere out of intestines, and then this little stoma that comes out to the skin, either at the belly button or usually the right lower quadrant of the belly. And the patient can just wear a little Band-Aid over this, and every 4 to 6 hours they would put that catheter that's going around into that reservoir to empty their bladder. This is a conduit. This is just the ureters come down to a loop of intestine, and that loop of intestine is actually brought out to the skin, and the urine drains into that outside urinary collection device. And this is a neobladder, or orthotopic urinary diversion, where, again, the ureters come down. We have a drain into this sphere of intestine that we've created, and you're urinating out through your urethra. So typical patient preparation for these types of surgery, you have to have full discussions with your patient and full disclosure. What is their expectations of the surgery? Are they young and healthy? Do they want to wear an appliance? Are they sexually active, especially for women? If you take the anterior part of the urethra, the anterior part of the vagina, it is very then difficult to have sexual intercourse because we foreshortened your vagina. So all of these things must be taken into consideration when we're discussing surgery. Potency or ability, erectile function after cystectomy, nerve sparing or prostate sparing, all of those things need to be discussed. The type of bowel segment that we're going to use, has the patient had prior surgery? Do they also have a history of Crohn's disease or other things that affect their bowel? And then that would then affect what bowel segment we may use with the patient. And again, this is the segments of bowels that you can use to help create a neobladder or diversion is stomach, which is very rarely used, and typically small bowel, in particular the ileum is what's most commonly used, and we can also use large bowel and colon. So this is a conduit. This is actually one of my patients who had one kidney and drained into their conduit. So there's one stent, and this is just a few days after surgery. And so this is part of the intestine that we call it a rosebud. It's sort of draining out to the external skin. This is the patient's skin. This is a catheter or a stent that's placed in the ureter that's draining the kidney out to the outside world while the patient's recovering from surgery. I would say conduits in the grand scheme of diversions is one of the easier types of diversions for the surgeon to perform. There is a very high satisfaction rate as long as the patient's comfortable wearing an external device, that pouch to be able to store their urine. There can be some concerns about fear of odor or leakage of the device. It is an external appliance. It can restrict your social and potentially your sexual activities if you're uncomfortable being out in public in a bathing suit and people seeing your appliance. And typically we use the transverse ileum for that type of diversion. And again, this is just another schematic. So this is the end part of your small bowel, then going into your colon. This is the appendix. And this is the part of the segment that we use. So we take out that segment, and then we put your bowel back together so your fecal stream is in continuity. And then we plug the ureters into this loop, and this loop comes out to the skin, and this is what you see on the patient. Again, this is that same patient of mine with the stent gone. This is his midline incision healed. This is his device, his stoma, and it drains into an appliance like this. And then continent cutaneous diversion. So this is the diversion where there's no external device or appliance on the patient's skin, but the patient has to use a small catheter to then get into the reservoir to drain their bladder. Sort of clean, intermittent catheterizations of the stoma. And there's many different techniques to do this, different parts of the intestines that we can use. That's not necessarily germane to this talk. The Indiana pouch is probably the most common one used. And again, it is using part of the colon and the terminal ileum. And this is sort of how it looks within the body, that this is then the reservoir of part of the colon and intestine that we use. This is what the patient then will get brought out to the skin here, and this is the catheter that would then come in through here, and this mechanism here keeps the urine from draining to the outside of the patient, okay? So they would put the catheter in here, it would get into this reservoir and drain the new reservoir filled with urine. And again, this is just sort of how it looks. And you can bring out this stoma out to the right lower quadrant of the body or sometimes even the belly button. And this is another one of my patients. So the stoma is actually much smaller, obviously, than it is with that conduit that drains to a device. And patients can wear a little gauze pad or even a Band-Aid over that because there can be a little bit of moisture. But again, there's no leakage of urine. And they will, every 4 to 6 hours, put that catheter in through this. They feed it into their new reservoir and empty the urine that way. To have this device, you have to have good manual dexterity, the ability to use both hands to potentially get yourself to catheterize, and some other things you have to have. When we talk about urine being or touching intestines, there's a lot of metabolic things that can happen with that. So the intestinal mucosa can absorb some of the things in urine, and so it can change the way certain drugs are metabolized and some other metabolic things that we'll get into a little bit later in this talk. Again, the advantages of this type of diversion, there's no external device, which I think is probably the one that's sort of the sexiest to the patient. So there's no external device. They do have to catheterize themselves, a small stoma. No one needs to know that there's anything there, that their body or their body image is altered in any way. The disadvantage, it can take a little bit longer to perform. They need to catheterize themselves every 4 to 6 hours. You are at risk of having stones form in this device, in this reservoir, and urinary tract infections. And certainly if patients have a difficulty getting their catheter in and draining their new reservoir, that can be actually very dangerous. And you have to present to the emergency room, and you have to be in a situation where people can help you, because that is an emergency. If you cannot empty your reservoir, it's going to stretch and stretch and stretch, and it can rupture. So that is the drawback of this continent cutaneous diversion. An orthotopic urinary diversion, or a neobladder, as it's more commonly called, again, many different techniques to do this. I would say the most common is a Studer pouch, and that's using part of the ileum. And that's what I use, and probably most people in the city. And this is how it's performed. So here is the colon appendix. This is, again, the ileum. This is the terminal ileum where B12 is absorbed. And we tend to go back a little bit further, and we take out a fairly large segment of the small bowel, the ileum, and we then open it up, and I think I have some pictures of that, where we create a sphere, and this is what we call the chimney. The ureters come down here and drain into this chimney that then drains into this new sphere reservoir that we've then hooked up to your urethra. And so you can then urinate per your urethra. And this is, again, how it looks, sort of a schematic. This is the patient who has had a neobladder, a low midline incision. Again, it can also be done robotically or laparoscopically. These incisions are just drains that they've had in place during the immediate postoperative period. So no external device, no stoma. Here is what we call a pouchogram or a cystogram before taking out the catheter. This is what all of it would look like on a fluoroscopy, where here's the catheter and the neobladder. It's down in the pelvis. This is the patient's pelvic bone, so it's anatomically in the same location where the patient's bladder once was. We put contrast here. This is the chimney. The ureters are coming in here, they're plugged in here, and the urine then comes here, collects in here, and the patient voids. The advantages, again, no external device, no need to potentially catheterize, although certainly there can be issues where the patient is not able to empty per urethra and will have to catheterize their urethra to empty this reservoir. So it is an advantage that you are as anatomically after surgery as you were, similar to what you were before surgery. There can be some incontinence of your urethra where a patient may have to wear a pad or a panty liner, and 20 to 30% of the time retention where you're not able to urinate, so you may have to catheterize yourself. And the other thing is really learning to urinate. So that sphere then fills, but you're not getting the same messages you are as you're just sitting having your bladder fill before surgery. So you learn to urinate by something called Valsalva, and sort of using your abdominal muscles to then help you empty that neobladder. Postoperatively, patients are in the surgery anywhere from 4 to 7 days. There are drains left in place, so if there is a urine leak or other complications, your surgeon can know about it. Ureteral stents, some people leave stents, some people don't. I tend to leave a stent. So as the ureter is then plugged into that intestinal segment, there is a little bridge of a piece of plastic that can help the urine go past that so that anastomosis can heal. I think part of the conduit, where you will have the external device or have to catheterize, having an excellent enterostomal nurse or wound care team is crucial to the success of the patient and recovering from the surgery, and how to use those devices. In some of these diversions, you have to irrigate your reservoir because mucosa of the colon makes mucus, and mucus can be a nidus for a stone, so patients can get stones in their neobladder, and so you may have to irrigate. And all of this comes down to good patient education and a good team to help the patient recover from surgery and then long-term their follow-up. Some of the metabolic issues are things that changes in your normal homeostasis after surgery, because again, now your urine is in contact with intestine, and that's very different. The intestinal mucosa is very different than your bladder, and so it can absorb different things at different rates. And also the loss of that small bowel, how does that affect things? Osteoporosis can be a significant risk. Actually, depending on how much bowel is used, cholelithiasis or gallstones can form, and you can also have, again, stones within the urinary diversion or within the kidney themselves, again, related to changes in calcium and phosphorus and all these other things. B12 deficiency is something that you should be monitored for if you've had a diversion, again, because the terminal ileum helps absorb B12. So after several years, and we typically have enough B12 to sustain us for 2 to 3 years, but testing should begin, and if there is a B12 deficiency, it's easy to replace either orally or through an injection. Bowel function habit can be altered because we're using part of your intestine. So we take a piece of your intestine out, we use it for something else, then we put your bowels back together in continuity. And so people notice changes in their bowel habits, maybe diarrhea, maybe constipation, some other things that go on. And there's many different ways that we can sort of troubleshoot that and figure out what's the best way to help you get through that. For diversions, again, I think the most important thing, again, if you're having a continent diversion where you have to catheterize yourself, or a conduit where it's going into a bag, a huge part of the team, and at Walter Reed we have Ms. Sharon May, who is instrumental to everything, is having a good enterostomal team that can help you get through that process. Urinary diversions themselves require significant follow-up imaging to make sure that the ureters and your kidneys don't become obstructed, that you maintain good kidney function. So that's lab follow-up, B12 levels, and obviously, again, good cancer follow-up in terms of imaging and cytology. So I believe surgery is still the cornerstone of treatment for invasive bladder cancer, and maybe that will change either chemo, and certainly there are bladder-sparing therapies to include chemotherapy and radiation, and there was just a very good article in the New England Journal of Medicine from Dr. Shipley going over one of his studies with radiation and chemotherapy. And again, the choice of urinary diversion must be individualized to each patient and what their expectations are and curative intent. Thank you.